Yeah, the cortex does look a bit more like a 50, 60-year-old.
Believe me, I hope your brain doesn't look like this. Yeah, this is, it looks like an old person's brain.
Yeah. Yeah, I agree.
Okay, I'm sorry, okay.
So, the presence of echocardiac evidence of left ventricular hypertrophy has shown to be independent associated with an increase in all-cause mortality and morbidity in the case of lupus. And in the absence of...
Okay, I'm going to interrupt you on that one too. So she couldn't have been normal because she had hypertension. And again, you guys know better than I do. I haven't done internal medicine in a long time. But for her to have LVH means that she had to have had the hypertension for X amount of time. It didn't happen in 3 weeks.
Yes.
Yes, agree. Yeah, the LVH shouldn't have been kind of an acute thing. It must have been there for quite some time. So, Sai Charan, when did we notice this LVH? During her second admission or during the first admission?
In her first admission
itself, which was in 2021, and that was her first acute presentation.
Yes, sir.
With the skin lesions.
And first hospitalization in her lifetime also.
Yeah, with the skin lesions.
With skin lesions.
But minus the meningeal lesions.
Yes, sir.
Alright.
So she had to have had a chronic process going on. And then when we talked previously, you said that she really hadn't had any encounter. I mean, she hadn't had like a routine physical, no one would have checked her blood pressure prior to this.
Yeah, well, she had a 170/110 when she presented the second time. What about the blood pressure in the first time?
130/70, sir, at first.
So, in the first presentation, there was no hypertension recorded. But it's possible that she may have had it. And is it possible, Michelle, that she's having a chronic vasculitis, which is also leading to the cerebral atrophy, let's say for 5 years prior to that, and only the cutaneous manifestations bring her to the doctor? The other
Yeah, but you don't have, she wouldn't have had an asymptomatic vasculitis for 5 years. You have to have symptoms.
Yeah, something like a microvascular involvement, which is, a very slow kind of indolent inflammation, which of course doesn't fit into lupus, but it fits into other kind of possibilities.
I don't know. That's how I was going back to the family history. I mean, she's young. There's a lot of pediatric illnesses that or genetic defects that I'm not familiar with. But she sounds like she does have a pre-morbid condition. She's got LVH, and goes from being a good student to a poor student. Then this isn't just an acute episode. But anyway, keep going.
So, these are neuropsychiatric manifestations. Our patient has headache, cognitive impairment, mood disorder, and she also, and one of the differential considered was antiphospholipid antibody syndrome, where the APLA involved associated with small vessel disease are associated with stroke, secondly to microembolism, and they could be associated with more severe cerebral atrophy. There was no relationship between cerebral and corpus callosum volumes and the estimated lifetime corticosteroid dose or the presence of antiphospholipid antibodies. So the anticoagulation therapy initially stuck between the aspirin and warfarin. In the review of literature, the warfarin and the cost effective to the patient, the warfarin was selected with a high intensity warfarin therapy to maintain INR in between 2.2 to 3. So with this,
what was the pre-warfarin INR? We knew that it was already elevated, INR and PDTK. So how did we adjust our warfarin to the prior elevation of INR?
Initially, at first presentation, our INR was 1.8, sir.
So that was elevated?
It was elevated.
From 1.1?
Yes, sir.
Okay.
Then in view of this embolic stroke, we started her on warfarin 5 milligrams twice daily, high intensity warfarin therapy, with a therapeutic range of around 3.
So our target was 2.5 to 3.
Yes.
Okay.
So,
Although it was already elevated, but we wanted to go on target to 2.5 to 3.
So after that, the patient was lost to
WebEx Assistant is enabled to save audio highlights.
with deranged INR, and she was symptomatically managed for intraventricularly. As her acute neurological syndrome has recovered after therapy, in my opinion of these 2 years, where I followed few cases, the analysis of neuroparalysis and recovery in our hospital for last 2 years. So the incidence of stroke among the motor weakness is high of 66%, and infective contributes to 10%, and vasculitis and CNS tuberculosis and neurosarcoidosis for 14%, of a sample size of 50 cases. This analysis
Oh,
of
this is
case
your hospital. Okay, that's interesting. Okay.
analysis of cases in a hospital in terms of outcomes, admission and 6 weeks follow-up. So admission power of our case was 4/5. After therapy and second admission follow-up, it was going to be 5/5 with a normal function. So she had 100% recovery, but still the hypertonia exists. In the terms of power, it is recovered, but the tone still she has a hypertonia, and also reflexes were exaggerated.
So it would have been interesting if you could have given her some kind of cognitive testing to see, because it still doesn't make sense that she was a good student, then she was a bad student, and then you say she was completely normal.
Yes, ma'am. In second
What-
admission, we did her MMSC, mini mental skills examination, ma'am. In first admission, she had MMSC of 18/30, which is a moderate cognitive impairment. But in second admission, in follow-up, recent follow-up, her MMSC is 30/30, ma'am. She could able to perform all her cognitive functions, ma'am.
Wow, okay.
So while on the surface there doesn't seem to be any cognitive impairment to go with the atrophy, but still her scholastic performance has reduced. So
Yes.
I think she may have required a psychometric assessment. And we have Dr. Rajkumar here. So next time she comes back, or we can call her and we can get a psychometric assessment for her as well. And this is a very interesting point. The correlation between the radiologic atrophy and her scholastic performance, which has gradually reduced, which is very, very unusual, as Michelle too pointed out. Yeah.
Yes, sir. So the wrong notion that always all positive anti-nuclear antibodies always mean lupus. But according to the statistics, not always the positive ANA is significant for a lupus. Thank you.
That's very good, thank you. Actually, I have to tell you, in this week's January 26th, I shouldn't give you the answer, of the New England Journal, if you can get it, is someone with catastrophic antiphospholipid. It's an excellent article, and it just really complements what you were saying. I just was tickled when I opened it. I still read the New England Journal every week. So if you can get it, I would highly recommend it to see. So this is a very complex case. And you said that you will be able to do nice follow-up with her, or you don't know?
Yes, ma'am. Actually, she is under online telecommunication follow-up, ma'am. And we are planning to do her renal biopsy, and also we are planning to send antiphospholipid antibodies also, ma'am, in next follow-up.
Well, the problem with the antiphospholipid antibodies is you may not be able to detect them now. I mean, you've immunosuppressed her.
Yes.
So if they're negative, it doesn't mean that you don't have them. So you'll do the best you can. And then, of course, to get her off the prednisone as quickly as you can. So you'll see the case in the New England Journal, which was also in a young woman. She had catastrophic antiphospholipid, and they were even more aggressive. But it sounds like she's doing okay with what you have at hand. So good luck with her.
Thank you. Thank you.
Yeah, Michelle, it's very interesting that you should say that, because the next case that we are going to present had a close differential of catastrophic antiphospholipid antibody syndrome. And yeah, can you keep the slide to the to the cutaneous lesions? Yeah, there. Yeah, that one maybe. Yeah. Okay. So I think we should now introduce Michelle to the audience as well, and Michelle's work. Like, she is a global rheumatologist, and she is trying to teach rheumatology around the world, and she has also visited us in the past, and she has been to many places in Africa, and she is encouraging people there to take up rheumatology as a profession. And interestingly, many of our students later on, became her students, and they're also assistant professors, I think, right now in the same institute where Michelle worked. And you remember Michelle, isn't it? One of them.
Not at Jefferson.
Yeah. There was one girl who told me, and then you also said, yeah, she was.
Moshe Mustek. He wanted me to help him. I couldn't help him. He
No.
was going to go into rheumatology, and I'm not sure what happened.
No, there was one girl who became your faculty at Jefferson.
Oh, Shristi.
Yeah, Shristi, yeah,
It wasn't
Shristi.
because of me. She had met you. So it's just a small world.
Yeah.
But no, she just appeared at my institution, but I had nothing to do with her getting there.
Yeah. She was our student who just became a faculty there, and then of course I think we have a lot of students here in the audience who would probably be going. Some of them would be going to US, and perhaps you will be able to meet them there. And
I would love to. I mean, there's really a worldwide shortage of rheumatologists, and our association rheumatology for all. So when I saw you, I didn't have the organization, but it's very expensive and it's a lot of work. I mean, we've sponsored 2 people who have successfully completed their rheumatology fellowship, but they were from Ethiopia, and we sent them to Durban, South Africa. And then we're in the process of sponsoring 2 more people, but it is agonizing to get them to go through all the paperwork.
It's a lot of paperwork.
But anyway, I'm trying to do something more online, and that's where we'll stay in touch, because so you don't have a rheumatologist there right now, right?
Yeah, not here right now. Yes.
Not there. Yeah, so that's all over the world. That's the situation. So we're trying to figure out how to be more effective virtually.
Yeah, and probably this session itself, this virtual session, is one of the things that you are, it's a part of your workflow, your global workflow that you are doing, isn't it?
Yes. So actually, what I'll do when I finish it, I'm making a PowerPoint on Twitter on how to find good rheumatology sources using Twitter. And if I can, you don't need, I'll send you the presentation when I finally get it together.
Yeah, that sounds interesting. I'll be looking forward to that. So would you like to discuss a little bit more about this particular patient, or shall we go to the next patient who had a catastrophic presentation when she came to us for the final time?
Yes, I'll do that, but I may not stay because I have office
it's your
hours
bedtime.
early tomorrow. So I'll stay for like about 20 more minutes, and then I will fade away.
Okay.
And it's always a pleasure to speak with you.
So should we start the next presentation on the similar patient, but who had a catastrophic presentation when she came to us? Are we still there? Can you hear us? Yeah, I think we have disconnected.
I can hear you, but I don't see the.
Okay, yeah, they're doing something here. I think they're opening the next presentation. So,
And then I gave the previous speaker, I gave him a review article on antiphospholipid antibody as well
yeah.
that he should share. Yes.
Yeah, so we'll go into this next patient with Dr. Manisha. She is a final year MBBS.